Welcome, everyone. I'm Paul Irwin, Dean of the School of Public Health here at UAB, and I'm excited to welcome you today to our webinar, The State of COVID-19 in Alabama. Today's webinar is made possible by the Office of Public Health Practice and the Public Health Student Association, the PHSA. Please take some time to visit the Office of Public Health Practice, OPHP, website to see past seminars, and always check the PHSA calendar for upcoming meetings and events. Let me introduce our panelist for today. Dr. Selwyn Vickers has been the Senior Vice President and Dean of the UAB School of Medicine since 2013. World-renowned surgeon, pancreatic cancer researcher, and pioneer in health disparities research. He is a member of the National Academy of Medicine, formerly known as the Institute of Medicine, and of the Johns Hopkins Society of Scholars. He has served on the Johns Hopkins School of Medicine Board of Trustees and the Johns Hopkins University Board of Trustees. In addition, he has served as president of the Society for Surgery of the Alimentary Tract and of the Southern Surgical Association. Dr. Vickers has been the preeminent leader for UAB among the many task forces responding to COVID for our campus, for the UA system, and across the state. I've had the honor of serving with him on several of these groups, and I am amazed not only at his breadth and depth of knowledge, but also for his ability to be on Zoom, by computer, and on his cell phone at the same time. Dr. Vickers, like me, is a native Alabamian. Dr. Mark Wilson is the health officer for Jefferson County, Alabama, and is the CEO of the Jefferson County Department of Health. He oversees a $55 million budget with a mission to prevent disease, assure access to quality health care, promote a healthy lifestyle and healthy environment, and protect people against public health threats. To achieve this mission, Dr. Wilson oversees health department programs in air quality, restaurant inspections, school and other facility inspections, and 6 clinics serving over 200,000 patients each year. As with Dr. Vickers, I have also had the honor of serving with Dr. Wilson on various task groups, including Representative Sewell's 7th District Task Group to advise her on reopening in Alabama way back in April and May. And Dr. Suzanne Judd, who has been with the UAB since 2009 and is currently a professor in the Department of Biostatistics and the director of the Lister Hill Center for Health Policy in the School of Public Health. Dr. Judd is a nutritional epidemiologist who specializes in reducing health disparities in chronic disease. Her research focuses on the role diet plays in racial disparities in the risk of hypertension, kidney disease, and stroke. She specializes in why different racial populations have different health outcomes based on their diets and other factors. She is the principal investigator for the REGARDS study, an NIH-funded study that examines the reasons for geographic and racial differences in stroke. She is also PI of the Rural Study, focusing on identifying reasons for health inequities in rural populations, especially in the South. It has been an honor and a treat for me to work with and call on Dr. Judd to help in modeling COVID at UAB, across institutions in the state. So with those introductions, I'll launch into a few questions. I'll be asking questions and moderating this session, but we hope to make it as conversational as possible. And I'll ask and remind our panelists to remember to please unmute your microphones. So to kick us off, if I could have each one of you take a couple of minutes and give us a flavor of what you've been doing these past several months. And Dr. Vickers, I'll start with you and the response to COVID by the UAB healthcare system and your work leading various task groups for reentry.
So Paul, thank you for the opportunity to participate. One of the unique pleasures I've had through this crisis, if you would, is to actually work and partner with you across the landscape of our community. I've admired your leadership and expertise, and both as a dean, but as a institutional and citizen of the state in supporting this effort as a co-leader with me for many of these these opportunities we've had to serve our university, our system, and our state. So thank you again. I think one of the things that has been the focus of what I participated in, and largely our UAB medicine side, I would say that we have first of all grappled, but we're very much grasped the science and the challenge of this virus. The term novel is used loosely, but it's novel in many ways of what it's forced us to do on the healthcare arena, both public and acute episodic care. I think initially it was really seeing our hospital restructure itself, create a command center, and not wait till the first set of cases became overwhelming, but to do that in anticipation because we knew the data and the science were really relatively, although new, were truly credible. And so organizing acute care floors for COVID, organizing ICUs, and a command center that would drive information daily. And then I think to remind people, again, the term novel particularly means we hadn't seen the virus, couldn't predictably understand all of its impact. And secondly, we had no therapies for it. So the initial care that was provided was all supportive. And your outcome was really very much what you brought to the table. If you brought chronic disease as a result of disparities in care, you suffered greatly. If you were young and robust, you probably didn't even get into the hospital. And if you were, you did fine. And if you brought age, if you were older, you brought those factors. So over time, we had to create, and our ID team led this way, as many in the nation had to create treatment algorithms that had to be built on the fly, if you would, building the plane while flying. Trial drugs that, in this case, remdesivir. 2 years ago, Rich Whitley got a U-19, and I remember doing a public announcement and speaking about the #1 project was therapeutics for coronavirus. And I really sort of laughed under my breath and said, who cares about coronavirus? Consequently, 2 years later, we all care about coronavirus. And remdesivir was a failed drug for Ebola, repurposed for coronavirus. I think after we step away from the acute setting to end up on, Paul, you and I worked to try to help build a re-entry plan for our academic institutions that encompass the education, obeying the public health strategies around PPE and social distancing. We were fortunate enough to work with brilliant scientists in our sister schools with Sue Feldman and Mohan Thirumalai to use their AI-driven web-based COVID screening tool. And then Kurt and the state Department of Public Health with your involvement and immensely to set up the algorithms on Health Check, but also to set up the exposure notification app. I think those have given us a credible opportunity to help both with testing, which we did to bring our students back, to provide that testing for students across the state as well as our citizens. And I think beyond the sort of larger universities that have Greek and college experience as a big part of their agenda, the rest of the schools like UAB have benefited greatly from these tools and are managing through this in a reasonable way. So I'll stop with that, but thank you for the opportunity to share about how I've worked sort of 2 jobs like you have as well.
I think you've had 3 or 4. Dr. Wilson, I commented to you not too long ago that I used to see you frequently jogging along Highlands, but I've missed you for a few months. I know you've been busy doing something. So tell us about what you've been doing at the Jefferson County Department of Health, please.
I did fall off the wagon in terms of my regular morning runs there for a few weeks. I'm back on partially, so.
Right.
Yeah, so it's been a really wild ride. I guess it really all started in February where we started planning, just like the university did, and starting to talk with partners in the community about how to plan. But it's run the gamut along a lot of different issues. I think early on when the pandemic hit, I was personally focusing a lot on policy decisions we were in panic mode, really, looking at what was happening in other countries, looking at what was happening in Seattle, Washington, New York, and really thinking about, a potential, disaster zone, and especially in our hospitals, looking at what happened in Italy, where people were being taken off ventilators to put other people on ventilators because of just being completely overwhelmed. So for me personally, it was just like the house is on fire and we got to do something now. So a lot of it was the policy side, figuring out how to write orders, public health orders to close restaurants, bars, and other parts of the economy. I was the first in the state to actually do that, and very quickly turned to the state health department to follow suit for our surrounding counties. But that all started in mid-March with a recommendation to limit crowd sizes on March 13th, and then my first actual order on March 16th. There were several others that followed. So I was spending a huge amount of time on that, and with my legal counsel and trying to get all that worked out, and then with my PR department on messaging that to the community. And then I think interacting with elected officials, to make sure that they were on board with all of that I was doing. And that interaction has been ongoing since then, but making sure that all of our local politicians knew what we were doing and why we were doing it, and getting their support, which I would say was really very remarkable at the beginning, because I think everybody was very, very worried. So it was a rare moment where public health was leading the way, and all of our local elected officials were on board, 100%. I can't say that's true now, but at that point, because we were all in panic mode, everyone was. Very soon after we started the policy side of things, we were instructed by FEMA to join with the local emergency management agency and joint incident command, which I co-lead with the head of the local EMA. And we built out a whole huge sort of structure, restructuring the health department in incident command, which we had already done earlier, but and then bringing on board multiple partners in the community, different governmental entities, first responders, people at UAB, et cetera, to all work together in a coordinated fashion. Not always well coordinated, but trying to coordinate things best we could. Early on, there was a lot of focus, and I had a lot of personal energy behind trying to make sure our vulnerable populations were protected, our homeless community, our people that are in substance use treatment facilities, our minority and low income communities, our housing community, et cetera, because we knew that they were really at risk, and a lot of time and energy was spent trying to figure out how we could help protect those communities and educate those communities. Coordinating testing efforts, assuring access to testing, for people that might not traditionally have good access. A lot of time on communicating with the public, news conferences, news interviews. I think in the peak of this, I was probably interviewed 4 times a day for TV, or at least it seemed like it, several of us. That's still going on at a lower level. Just various opportunities to educate the community, town halls, calls with our faith community leaders, et cetera, just taking multiple opportunities to educate the community, partner with the community. And then I think most recently in this last, 2 months or so, a lot of my focus has been on our schools. The university system, our partners here on this call have done a great job with planning that for not only here, but for the state. But I've done a lot of work with our local school superintendents and trying to make recommendations and guide our schools as they start to reopen. So those are just some of the highlights of what have been sort of on my plate personally as head of the health department and as the county health officer.
Fantastic. I don't usually mention Wikipedia as a frequent science reference, but I've been working on a paper recently and have found that Wikipedia has a page for each state's timeline. So you can look at COVID-19 in Alabama, and it's a very nice timeline. And if you go there and look at the timeline, you will see usually first in a set of actions what the Jefferson County Department of Health was doing. And that's a testament, Dr. Wilson, to your incredible leadership, and, for which we're very appreciative. Dr. Suzanne Judd, Dr. Wilson mentioned media. It seems like not a day goes by that you're not doing one or more interviews, translating your high-level science, your modeling work to mediums media that people can understand. It's been phenomenal work. So talk about both of those aspects of your work recently.
Yeah, absolutely. I think speaking with the media is something that's so important for us to do in public health, and finding a way to communicate in a way that is relevant and relatable without being judgmental. As I was looking at this call, a lot of people, if they look at my CV, would say, why is she so involved in coronavirus? But I actually trained to be an infectious disease epidemiologist at Emory. I wanted to follow in the footsteps of In the Band Played On. I thought I was going to be Matthew Modine someday. Don Francis, really. But as I got there, things had changed a lot in the HIV epidemic. But one of the things I found fascinating from the story of In the Band Played On was the way that the community gets involved, the way that the public is so important in how you can control a disease spread, and how if you don't get ahead of something with real information for people, then the alternative narrative can take control. So for me, speaking to the media is a really important thing that I do. Even if it's just short clips with the media, it's important to hear from scientists, and it's important to hear from scientists using words that people typically use in their daily conversation. That just helps people understand what's going on with this epidemic. Also to be relatable and let them know that I'm struggling as much as they are to figure out how I'm going to run, like Dr. Wilson said. How am I going to work out? I went to the gym a lot. And so things like that. How do I now change my life in the face of this pandemic? And I just think that helps people to receive your message if they realize that you're not a robot that was just waiting for this opportunity to sit in your house all day long.
So well said. Getting used to working from home for months on end was a new reality for me as well. Well, thank you for those opening comments. I have a set of questions to follow and connect to those opening comments. And Mark, I'll start with you. From your perspectives from the Jefferson County Department of Health, where do we currently find ourselves with the COVID-19 pandemic? And what can we expect as we move through the fall? What does your crystal ball say?
I've been looking for that crystal ball for quite a while, and people are always asking me to look at it. So I was actually thinking about asking for some federal CARES Act money to pay for a crystal ball. That might be a good investment. But yeah, I think to that point, really, I think what we're looking at is a huge amount of uncertainty. I mean, right now in Jefferson County and in Alabama, we are seeing relative improvement in our numbers of cases per day. I would say this past week has been a little confusing. Some of the numbers have ticked back up, and we're still trying to sort through that data to figure out what that is and how real it is. But really through the month of August, we've seen pretty dramatic improvement from what was a horrible onslaught and increase through late June and July. And, you know, we all know that there could be a resurgence in the fall with cold weather, with flu season superimposed. And these are things I think most people are aware of. But I think one of the take-home messages to me is that this thing, Suzanne may disagree, but this thing is kind of unpredictable and to some degree takes on a life of its own. I don't think we would have said back in March that we would expect to see a big, huge peak in the middle of the summer, for example. But that's what happened. So I'm nervous about the future. I'm nervous currently about schools reopening, colleges coming back to campus. Students coming back to college campuses in spite of great preparation. Labor Day weekend. Also, I think just the public's ability to hang in there with this through several more months. And we've seen a lot of that even from May and June, a lot of antsiness among the public to be done with this. So that's just looking forward makes me, I guess, nervous.
Yeah. Thank you, Mark. Suzanne, you're a modeler, predictable or not, and how do you work with your models to in such a context of uncertainty?
Sure. The disease itself is predictable, but human behavior is not. That's the big challenge with this particular virus. I do think a lot of what we're seeing is predictable. I think that there were a lot of people saying when K-12 and universities reopen, it's just going to pose a unique challenge we haven't faced yet. So I think that was something we were thinking about. The degree to which we faced it, particularly for universities, was, I think, much larger than we thought it would be. I think K-12 is still an unknown. We just don't know how children shed the virus and spread it to each other. And we have this general feeling that for every 2 cases in adults, there's 1 asymptomatic case out there somewhere. We don't know for children what that is. If you find 1 case, I'm a Homewood parent, and we got a note that there was a case in Homewood Middle School a couple weeks ago. How many asymptomatic kids are there for that 1 symptomatic kid? Was it 3? Is it 1? What is it? We just don't know. And the K-12 schools don't have the same funding the universities do. So Alabama can do widespread testing to cast a huge net to identify all cases, even in people that are not symptomatic. K-12 can't do that. And I think that we're really going to struggle as a community as these cases start leaving the schools and heading into parents, and it'll be one of the things to watch. I personally am quite nervous for early October, mid-October. That's the time I'm watching in cases. We're already seeing really big growth right now. That's when they'll hit the hospitals, and that's when we could see a huge surge coming out of K-12.
Selwyn, as in your role as head of the UAB hospital systems, the healthcare side of UAB, what's your perspective on where we are right now, and how do you see the fall unfolding?
I will clarify that I usually have gone to each of you, Paul and Mark, for sage, wise advice, but Suzanne's my crystal ball. When I need to figure out something, I go to her. So I've found it, Mark, if you think you need help. Suzanne does great work to help us understand what may be maybe not well thought out just from our linear knowledge of the disease. I would say that, the partner that I have in leading UAB medicine, Reed Jones and Will Fernandy, as we talk, I would say weekly, I think there is a couple of concerns. I would say one, as I think we have right now a baseline level of interventions. And as everyone knows, our interventions are fairly blunt tools. And we are using those around the mask order, around social distancing, limiting group size. But to those baseline level of tools, we're adding more and more activities. Suzanne highlighted to those baseline tools, we added colleges coming back. We've added K through 12. We're going to continue, and clearly we are perturbed by those holidays, right? So those holidays perturb the baseline level of activities we have to protect us. And at their baseline, they can maybe protect when we're doing normal, but when we add these other things, we don't often have the same capacity for the protection we need from those baseline activities to overcome the human behavior that occurs associated when we now add these other components back into our realm. So I worry that we will be on a bit of a roller coaster, like Suzanne said, and then maybe as Mark clarified, that we won't be out of this. We will probably be in a slow burn with peaks of stress related back to admissions, related back to case explosions, and then tampering back down to the next event that occurs. And then when the next event occurs, we'll be back up again. That I think will be our, I hate to say our expectancy of the course. I don't know that we have the cultural environment that can mimic a New York. So I don't think a complete shutdown is in our toolbox anymore, even though it's on paper. So with that said, I think it's the course that we will end up facing that will have multiple episodes of stress on our systems throughout the year in some cyclical fashion.
And Mark alluded to this sense of a roller coaster with the recent uptick in cases. And if you follow the graphs that Andy Rux and Jack Duncan do daily and Maria White post on our website, you can see that 14-day moving average ticking back up for Jefferson County and for the state of Alabama. But just today, I noticed again a little downward slope. So the roller coaster effect. Mark, we have a question in the chat box for you. Have you been surprised by the resistance to mask wearing in the community? And what has been your strategy to increase mask wearing compliance?
Yeah, I don't know if I was completely surprised. I think, because I think we're all aware of some of the divisiveness in the community, some of the politicization of this whole thing, and some of the anti-science sort of rhetoric that's out there. So I would say, I think the word disappointment has been more of a word than surprise. I mean, I just think the general idea that masks are, have been about us caring for one another as human beings and as a community. That's been the thing that the predominant emotion for me is just disappointment that folks aren't willing to make a minor sacrifice for the benefit of others and sort of a sense of us being in all this together. And I think a bit of exasperation, despite us messaging that and saying it's not about you, I think a lot of naysayers in the public continuing to come back and re-emphasize that it's about them personally. It's my decision, it's my rights. It should be my decision about me and my family. And it's kind of, that's just been disappointing and a bit perplexing. I think in terms of strategy, I mean, a lot of the strategy was just deciding whether it's, public relations, education versus orders. I sat on that fence for a couple of months. I remember being asked by news media, probably in late May, was I going to issue a countywide order for masks? And I said, no, I'd rather not. I'm depending on the community to do the right thing for the right reasons and trying to be positive in my messaging. But eventually I did issue an order in late June, which was highly controversial. I mean, it was amazing that after having basically shut down the local economy and I think I put 60 or 80,000 people out of work in one day, which was, I mean, the gravity of that was huge for me personally, and of course for those that were put out of work. But I didn't get nearly as much. I mean, the most hate mail, if you will, and pushback I got in this whole thing was over wearing a silly little face covering. And that was just amazing to me. But we did initially, we went ahead and did an order, and then eventually the state did it. But part of the calculus, though, was do we do it now in the summer or do we reserve it, if you will, for the fall when flu season hits? And I remember that discussion internally, if we do it too early, will it sort of lose its effect, if you will. And I made the decision to go ahead and do it and try to normalize it, and just make it so it became just a normal thing for all of us to do well in advance of flu season, rather than waiting until then to pull that out of the toolbox. I think that was the right decision, because now I think it is, relatively speaking, it's pretty well normalized. Some may disagree, but that's been my observation. I've been amazed to walk into a convenience store and see every single person just kind of automatically putting their mask on, and also standing in line 6 feet apart at the cash register. So it's been pretty amazing to see where we are now compared to where we were 2 months ago.
Right, and again, I think your leading the way was part of the impetus for the governor to make the wearing of masks a statewide mandate, and something that she has extended now twice that we're really pleased with. As I'm sitting in my office facing University Boulevard, I can see folks walk up and down the sidewalk, mostly students who identify by their backpacks, and with rare exceptions, they're masked. So that's, I think, again, good public health practice at work. Suzanne, you alluded to this in your comments about mid-October, and maybe you can expand on this. What keeps you up at night?
That's, I honestly, schools reopening have kept me up at night since May. It's all of the models that were built, even the ones from Washington, from Harvard, everything was built based on shutdown. We didn't have a lot of transmission data in free living communities. We had some out of Wuhan, but that wasn't exactly readily available either. So we just didn't have data to feed into the models about what would happen if children were getting together. Even as I've been trying to do some models for universities lately, I was trying to use the Sweden data because that would be the closest we have to free living populations. But as I dug into their health orders, they closed down universities. So even though they were wide open, they didn't let 18 to 24-year-olds get together. So it's just been really hard to find data, and knowing that we didn't have a lot of data on transmission in young people, that's been what keeps me up. I'm curious to see what happens. How much do young people mix with older people? A lot of these remain to be seen, but there is a dire consequence if it's as bad as it could be. So I'd say that's what keeps me up.
And to that point, Selwyn, I know that you've been involved statewide, not only with the University of Alabama system, but with all institutions of higher learning. And in that regard, as institutions are really all now starting back up, what are you most concerned with right now? What keeps you up at night?
Paul, I think similar to what Suzanne and Mark spoke about, what I'm reminded about in this behavior piece that Suzanne mentioned and Mark as well, this virus has had the unique ability to do a couple things. Number one, as it relates to populations that have health disparities, it's linked lethality to it greater than anything we've seen. The second thing that really applies to our college world, this virus takes advantage of the attributes of our country, our culture, and our community that we often are proud of. Being nonconformist, being independent, having a mindset to go it our own way, to forge ahead in spite of difficulty. Those attributes in most arenas work well, but in this one, it doesn't work well. It actually is, it's a weakness. And so I worry about the fact that the nature of who we are as an institution and as people, as a region, it's an uphill battle. And a lot of times when I try to either move the needle with culture or move the needle in doing things, I look at external data to compare. And I know that in many ways, we're proud of how our country is doing, and we're appreciative of all the hard things that people on this call are doing. But when we compare ourselves to the rest of the world, we're 5% of the world's population, we're 20% of the world's cases. That just doesn't add up. And it does lend to the fact that maybe this virus has taken our strongest points and used it as our sort of our weakest links. But I do worry about the ability to control behavior in order to obtain the things we want. And sometimes we miss the point, as Mark initially said, the pushback to wearing a mask was not to be draconian. It was just to get to the place we wanted to be, where we actually had control and potentially had some freedoms. But I worry about that cultural experiment around behavioral health and how that will not change until we get a successful vaccine, and just a lot of lessons to learn as we go forward. But our fatigue too. I think we're all tired.
We have another question in the chat box, but I was going to comment because your comments are closely connected to Mark's sense of simply an expression of caring about each other in the wearing of masks. That this is not about me. This is about actually me protecting you. It's something that we're challenged with. It's something that we've been challenged with as a society more and more with things like vaccine. And it worries me about a potential COVID vaccine. I will never forget the words I heard from a woman in California speaking in the context of the measles outbreak that was going on there, saying essentially, I don't want to vaccinate my child, but I want you to vaccinate your child so my child will be protected. That's not the kind of caring that I hope that I think that we're about. But to the issue of herd immunity, we've got another question in the chat box, and I pitch this for any of you who would like to answer. Can you respond to the current thinking about herd immunity? That is, that we just need to go back to normal activities and allow the community to contract the virus at a level until we've reached herd immunity, even without a vaccine. And Suzanne, you alluded to Sweden. I think that was what they attempted there as well. But to any of you, Selwyn, Suzanne, Mark, what about this notion? Just let everybody get sick. Let everybody get it and be done with it.
It's just a huge risk. We don't know the herd immunity level for this virus. We think it's somewhere between 55 and 65%. But we don't know whether or not this virus will ever have herd immunity. You could be reinfected with it. And this could be a virus that the more you're infected, the worse your long-term consequences are. It's a roll of the dice that I guess everybody makes internally for themselves. But I just ran a calculation for some people that were asking this very question. And the question is, how many people are you willing to lose in order to get herd immunity? We could lose up to 4 million Americans if we're going for that. It's a lot. We've only lost 180 right now, 180,000. 4 million, that's a lot more than we've lost. And it will hit you. It will hit somebody close to you if we let it go unchecked. And the long-term consequences, all of these things that we're finding out about heart conditions in the long run, lung conditions, VTE, stroke risk. It's just a huge risk if we're going to wait for herd immunity. And it so far hasn't worked that well for Sweden. So.
And Selwyn, I would think that following Suzanne's comments, I would think that the healthcare system, that the risk to the healthcare system being overwhelmed and inundated in trying to care for large numbers of people who would need to be hospitalized.
Yeah, I think it would be massive. And it would also, I remind us that probably, and I think everybody on this call knows this, the webinar knows it, is that there are very few illnesses that we take care of in our current world where people die alone. So everybody with COVID dies alone. Most of the other people who are at a point and who get the privilege to come to a hospital, get treated and not make it out, so there's some prolonged period, they die with their families and an opportunity often to say goodbye. Doesn't happen with this. And so you expose not only the system, but particularly its personnel to a significant amount of major trauma and exposure if we were to do that. I think too, just like Suzanne said, those numbers become immense. And I think one of the reasons people think about that, there are some easy courses in the scope of medicine. Epidemiology is not one of them. It's actually a pretty challenging science. It's not easy to be sort of a backseat epidemiologist, and yet people do, and you can in other things. There are other parts of our medical world where you can pick up a book and read and draw a reasonable conclusion. This is not the one. And so it unfortunately drives people to think about things without the clear understanding of not knowing what they don't know. And that's a dangerous position to be in, because there are bright people who've asked the question you said, why don't we do this? And speak loudly about it. But it's one of those things, is not knowing what you don't know, because it's a field that's not easily grasped. And I think we see the bigger issue, what you on the call will testify to, is that the role of public health in our healthcare environment has been limited up until this time to what it should be as a broader understanding of how we manage populations.
Thank you for that comment. I really do appreciate that. Mark, any comments about herd immunity?
I don't think I can add much to what's been said. It's it's an awful gamble.
Yeah. Mark, I'm going to stick with you. I know that each of you, represents a different arena. The Jefferson County Department of Health, the School of Public Health, the School of Medicine, and the UAB healthcare system. Let me ask you to describe some of the new ways of engaging with the other panelists, or the units or institutions they represent, that you've experienced as some of the, let's say, unintended consequences or benefits of COVID-19. So Mark?
Yeah, I mean, in terms of those that are on this panel, I mean, all of you have been people that I've leaned on. I've often said I'm not an expert at anything. And one thing I've done a lot of during this pandemic is pick up the phone and call somebody, or email somebody, or text somebody for advice. And so it's been a huge blessing here in Jefferson County to have UAB, epidemiologists, our medical community, our public School of Public Health. And we've been leaning on you all since the very beginning, because I've had, as I've mentioned before, I've had to make some decisions that have huge gravity, and I'm not the kind of person who likes to do that alone, I promise you. So it's been, I just think the relationships that we already had have really been strengthened. And it's not just our public health community or our medical community. It's all sorts of partners in our community. As I've mentioned before, relationships with our local elected officials. I've tried to maintain those relationships for general purposes as health officer, because we have other policy agendas and other partnership work that we do a lot of in our health department. So we try to maintain those relationships, and it's good that we have going into this. I would add, having those relationships, I think, has been one of the most important things about this whole process in terms of being prepared for it. But in the midst of it and coming out of it, there's strengthened relationships and all sorts of new relationships. I've gotten to know our school superintendents really well, and I really didn't have a personal relationship with more than a couple of them before this. And the list goes on and on. Certainly with our state health department, we've always worked closely with them, but now around this, much more. The state health officer is somebody I don't hesitate to call or just chat with at the end of a day to compare notes, see how things are going. The governor's office, multiple others.
Thank you, Mark. It's been great to strengthen the relationship between the School of Public Health and the Jefferson County Department of Health. I appreciate all of those opportunities that our students in particular have had in that relationship. Suzanne, your perspective on that, how do you engage with the ones who are represented here and others across UAB, and what's been the unintended benefit of this?
I've gotten to meet some incredible people across campus. This has really been a lot of fun for me in terms of work and people that I've gotten to meet and learning about what all goes on here at UAB and across the state even. Just having opportunities to work with different people to create student projects so the students can work with data and understand how data are used when they're being generated in real time. Those have been some of the unintended consequences in being a part of this team. And it's really been very interesting to get to know new people. The key to engaging though has been just being there regularly, showing up, for my piece of the pie and not trying to be a virologist or a health behavior expert, but just give my piece of expertise and lend help where I can.
I'm going to pick up on a couple of questions in the chat. And the way that I'm also going to continue to do this, seeing that we've got about 12 minutes left, is that I'll continue to track these questions rather than stopping, let's say, at 12:55 to see if there are additional questions, because then if we don't get any, we'll be sort of in a dead zone there. So the next thing that comes up, this sort of follows the herd immunity question. If herd immunity does not work, and if vaccines don't work, as we're expecting because of the virus mutating, then what next? What's left in the quiver?
Paul, I would say that as it relates to viral mutation of what we've seen in the past, there are clear examples where this virus mutates that may affect some level of its infectivity, but it doesn't affect our ability to detect it or the ability for the body to detect it. We see a little bit of that where people, these unusual number of cases that are small where somebody truly gets reinfected by a different strand. So I think when we think about viral mutation, on a scale of 1 to 10, this virus is not 10 on a 10 for mutation. I think it would be probably not wise to say it doesn't mutate, but I don't know that I would argue mutation will be the limitation of why a vaccine may not work. There may be other things that are prohibitive in how long the immunity lasts from a vaccine, based on how effective in neutralizing how long those neutralizing antibodies last. I don't know that it will all be due to the virus mutation. So I have some hope that the vaccine will have an effect. I think the question all of us have is durability, and we'll have to see.
Yeah, durability and uptake.
Yeah.
Getting people to actually take the vaccine will be a challenge. Here's another question, and I might take a crack at this because it actually came up in a conversation earlier. But all three of you actually are involved in adjudication of deaths, so please comment as well. Does anyone on the panel have any thoughts on the recently released CDC data showing that only 6% of deaths were solely COVID related and that most deaths were from underlying conditions combined with COVID? I'll just comment and then pass it on to any of the three of you that rarely do people die of a single cause of death on their death certificate. So this is not unusual at all. And the fact that with a large majority of these, people had comorbidities is exactly the thing that put them at risk of dying from COVID. So COVID was the immediate cause of death for the 180,000 deaths that Suzanne mentioned. It's just that a large number of these actually contracted and died from COVID because of the very reason that they had those underlying conditions. And if any of you would want to further comment on that, please do.
Yeah, we see this all the time, especially with mortality data. In order to make mortality data easy for epidemiologists like me to get, you have to lump it into bins. And then we like to study it and tease it apart. So then we had the underlying conditions. This was a debate in stroke several years ago too, because stroke fell from the third leading cause of death to the fourth. And one of the reasons was that people were coding death certificates as cardiopulmonary arrest. The person died from their heart stopping, even though it was a stroke that led to their heart stopping. So it was a big debate because stroke wanted to be back at the third leading cause of death. And the same thing is true of COVID. People will have underlying conditions, but the bottom line is they died because they got the virus. That's why they died. Now, hypertension and diabetes can put them at greater risk. But if you look at US adults, 66% of US adults have hypertension or diabetes or one of these other conditions. In young people, 18 to 25, one of the biggest risk factors has been asthma. And pediatric asthma is incredibly common. So to have an underlying condition, it's pretty hard to find an American that doesn't have some form of an underlying condition.
And Paul, I would say, 100% of people die from cardiopulmonary arrest. That is a known factor that they will die. I think it is a bit of a misnomer to parse out and remove the understanding that the initiating factor for someone's death, although it may be due to a failure of an organ with illness or with limited reserve before this started, was still driven by COVID, right? And that's the unfortunate thing, because the initiating driver was this illness. And yeah, maybe that 6% are those individuals who had no comorbid illness. They were young, but unfortunately it was the sepsis from the virus alone who did it versus the failure of an organ that didn't have a great amount of reserve to keep somebody alive. All started by COVID.
So we've got just about 5 minutes left, and I'll ask one more question, and then we'll see if there are other last-second questions that come up in the chat box there. And the question is, from your perspective and the work that you do, what skills, and perhaps I should say maybe new skills, do students need to help our communities better prepare to deal with the next pandemic or natural disaster? Suzanne, I'll turn to you first.
So I think we really have to figure out health communications. I think as scientists, we have to figure out how to control the message the same way that journalists already know how to control the message. Any way that we can get involved in terms of health communication is key. But for those kind of budding scientists out there or public health folks, use your entire toolbox. Whatever you've got in your training, use everything you have. I use my chemical engineering degree for the differential equations I have to use in modeling. I use my epidemiology degree in understanding the way that the infectious diseases spread. And I use my PhD, which is in nutrition, in understanding populations and health disparities and how people might differentially respond to diet specifically. But for this, I use all three of those. So use your whole toolbox when you're fighting something like this.
Selwyn, what skills do students need?
I think certainly on our side, for our medical students, they really do need, and I think they have gained a really broad appreciation of the power of public health and the impact it can have on our society. I mean, healthcare as it is now is episodic. It takes care of disease. It doesn't pursue health. I think public health is really crucial to pursuing health. And I think there is a real benefit from our students having a much better appreciation and understanding. We always have to fight for space in our curriculum, but this is one that I think will be beneficial, and hopefully more get excited about getting that additional degree in Masters of Public Health or even a PhD in an area like epidemiology. I would also say that one of the other powerful things we've seen around this is two things: informatics, that the ability to understand that space and participate in it is huge, because that's driven a lot of what we've talked about in being able to have tools to be able to convey information. And so it's an added skill that I think is going to be, and I would say informatics and data science is huge. The final thing, Suzanne mentioned this, that I think our students need not forget, is that no matter how credible your message is, you have to be present on some regular basis. I think the governor of New York probably demonstrated better than anybody that it wasn't so much the messages he said, is that he was messaging on a daily basis, which conveys a concern or care, a level of all the things you need to have for somebody to listen to your message. And if it's credible, then it becomes really powerful because you've created that sense of your presence, which, you know, as Mark said, it does convey that you care about the person as much as you care about what you're saying. And I think that is something that I think the students should not lose sight of.
Mark, we have just a little over a minute left, but if you wouldn't mind commenting, you hire some of our students from the School of Public Health and from the School of Medicine. What skills are you looking for now that we're in this pandemic?
Well, it's interesting that they, that communication was mentioned. I mean, that was at the top of my list. Public relations, communication, frequent, honest, multiple venues, multiple layers, different people, blending the science and the brain with the humanity and the heart. You gotta have the ability to engage your community, to engage with those that disagree with you with respect and compassion. We serve everyone, even those that hate us. So it's important. Understanding the politics, the big P politics and the little p politics, the statewide politics, the local politics, the politics that are even in our churches and in other institutions. And again, the relationships, extremely important. Those are all soft skills, quote unquote, but without those, you won't succeed. Emergency preparedness training, it's something, we do at the health department regularly, but it's kind of like, it's a bit of a nuisance. You don't always have time for it. But boy, when it hits, you're really glad that you had at least a semblance of knowledge around incident command and how to organize and prepare for pandemics. So take that seriously.
Fantastic. Fantastic. Well, we're at the end of our hour. I want to thank our three panelists, Dr. Mark Wilson, Dr. Suzanne Judd, and Dr. Selwyn Vickers for your insights, your wisdom, for your leadership. UAB, the state of Alabama, is extremely fortunate to have wise and thoughtful leaders such as you. So thank you. Thank you all for joining us for this hour, to all the participants. And with that, we bid you good day. Thank you.